Okay, we're live now. Welcome everyone to Being Patient's Live Talk. This is Nicholas, reporter with Being Patient, and today we'll be speaking with Dr. Robert Wilson, who's a neurologist and director of Cleveland Clinic's Autonomic Center, about COVID-19's effects on the brain and body and the neurological manifestations that infected patients can experience. So, Rob, thank you so much for speaking with us.
Oh, great. Thanks for having me today, Nicholas. I'm really honored to be here with all of you.
My pleasure. And Rob, I want to start off with, asking you, can you tell us a little bit about, your team's research focus on COVID-19 and how did your team first get interested in this specific area in terms of long COVID and postural tachycardia syndrome, and why is it important for your team to study?
So we're 2 years into this pandemic, and there are some rising numbers, but we always knew as neurologists that viruses can do a lot to the nervous system from different mechanisms, direct injury, inflammation, post-inflammatory issues. So we knew when this pandemic started in February, March of 2020, that we were going to see things. So we were sort of very alert and sort of pay attention to that. We're going to actually have work to do, help people, and be just very vigilant. I mean, as a neurologist, I was a frontline worker and just highly active in 2020. And then just waiting for what was going to happen. We've seen things with strokes developing, acute COVID, other inflammatory issues. And then something really happened in the fall of 2020. People came in suddenly in large numbers with, I had COVID. And then 3 or 4 months later after COVID, they were saying, I'm not quite the same. And that was sort of this thing. It was interesting how it happened. There was a shift of patients, still active COVID. There was still that winter surge of 2020 and the hope of the vaccine. But people really coming in saying, I had COVID, it wasn't so bad, mild, I function, but I can't think. I'm not able to finish my schoolwork, my coursework in college, my daily work function. I'm having thinking issues. I'm very fatigued, often dizzy, lightheaded, can't exercise. And Nicholas, I think you and I talked earlier, what was, as a physician, our first duty is take care of people and respect people's stories, was that we often see people, especially at a major academic center, often maybe 1, 2, 3 years into their symptoms. We were seeing people where I was a person who was athletic. I was a person who functioned really well. I was a go-getter. And then I had this virus, maybe not so mild, maybe just very mild. And then something happened. Now I can't do anything. My life is different. My brain is different. I can't think. And it was a very short window from day 1 of COVID. And now 16, 12 weeks later, a different person. And it was very interesting from a basic, you care about people, your commitment to medicine, but also in terms of research, seeing people in a shorter time window of onset of symptoms. I was a normal person, and now I'm a different person about 3 months, 12 weeks later.
So for you as a neurologist, you have these patients coming in, a few months after, they got infected with COVID, saying that, my life's not the same anymore. And, how do you define, what it is that they're experiencing? Like, what do you tell patients, at that point?
That's a very kind question that you ask, and a very relevant question. Is the most important thing is respect what people are going through. Many people in this time then and still ongoing they're really searching to be listened to and believed, because these symptoms can be thinking issues. I can't think. I feel unsettled. I can't get my words together. I feel very fatigued. What is fatigue? Often I ask people, what is your fatigue? It's hard to describe. And they'll say, I just can't get through my day, my work, my chores, my exercise. I can't take care of my kids as well. I can't get my job done. And then they'll tell about other symptoms: dizziness, lightheadedness, muscle pain, body pain, headaches. So I always tell people, I don't know what your dizziness is. Just tell me how it is for you in your own words. So I think the first thing is respecting what people are going through. And that's been an important thing about these sort of long COVID long haulers, people not recovering, is just allowing people to have a space to be recognized and knowing this is happening. I mean, the numbers are very impressive. It's all over the board, from like 6%, 20%, 30%. I mean, there's various numbers. It's not been universal because it's hard to study in various population studies how many people are not recovering, but something's happening. And to really respect that. And I think also these symptoms can be very confusing because they're not confusing to the person going through them. They want a diagnosis. They know what they're going through, but they're confusing often to medical providers because when you're feeling brain fog or can't think or fatigue, they're non-specific. Because you can't localize it or say it's really registering to a certain part of the body. If someone has a chest pain and pain going down the left arm, you can really often in the training of medical providers say that could be a heart attack, or someone breaks their arm, you can see this. But someone comes in and says, I'm dizzy, I'm weak, I'm lightheaded, I can't walk, my legs feel wobbly, and my thinking's off, and I feel very unsettled after having COVID. That can be what we call non-specific or non-localizing. You can't register to this one area. And it requires sometimes time with people, belief in people, and some skill to sort out.
Got it. And, yeah, you mentioned about long COVID, long haulers, and I just want to make sure, we understand, the definition here correctly. Yeah, tell us, like, is there like a consensus now in the medical community of what long COVID is?
Yeah, I mean,
and if there is, what is it?
Yeah, I mean, the definition is a great question. I mean, it's sort of arbitrary. We sort of had to pick something, what it means by definition. And it sort of is, you have to have COVID infection. So one aspect is it's very easy during that late 2020, mid 2020, 2021, people are getting COVID tested. We have positive testing, but there's people in the early 2020 who were just had these clinical judgment. But these are basically symptoms that are occurring weeks to months after COVID infection. Most COVID infections resolve within 1 or 2 weeks. Generally, there might be a belief that most of the symptoms should recover within 2 months after infection. If things are lingering, and we're talking about more about not like fever or sore throat, but more of these sort of global body symptoms of brain fog, aches, shortness of breath, difficulty breathing, muscle aches, can't function, dizzy and lightheadedness past 2 months, 3 months. That's more of that long COVID, which seems very frustrating if you're a person living with this, that you're going at week 6, week 7, and you're like, wait a minute, this seems like long COVID for me. So, I mean, these definitions are very arbitrary. They were selected, and maybe over time we might change it out to a shorter interval. So that's a very important question and relevant, because a lot of these definitions are based upon things we selected and that maybe are not as scientifically grounded.
Right. But at some point, like, you do need to create these arbitrary, criteria if you want to do research and define a population.
You got to start somewhere. Yeah, you're right. You got to start somewhere based upon research, other disease states where they are, and then maybe over time we'll see where most people fall and delineate from where they recover. Most people do have this sort of good recovery phase, and then we'll start saying maybe at 4 weeks, 5 weeks, people really, if they're not really recovered, this is where we need to be. And I think that timeline where we look at long COVID should always be evaluated and be looked at, so we make sure we help people out, because people might be impacted with work, school, daily life aspects, in terms of being evaluated in care. And this is not criticism of research or public health, but it's part of our duty is to constantly look at things that we measure.
Got it. And, and Rob, you mentioned that, there's been patients who, healthy patients or like athletes and people
Hmm.
like that who come after being infected with COVID and, telling doctors that, they're experiencing these symptoms like fatigue and brain fog and things like that. I was wondering, now at this point, do we know like what part of the population and what type of COVID-19 patients are actually at increased risk of having long COVID?
Yeah, and that's what we're trying to do in some of our research is do some pattern recognition so we can learn, help other disease states get some insights. We take people who in what were normal, whatever that means, but we have it, they were functioning people, and then this change. And we have done research on athletes. We've had people who had COVID. They were highly like competitive athletes who got COVID and got this POTS syndrome where they can't control their microcirculation, their heart rates in the 140s after being very athletic, and they're dizzy and lightheaded and fainting and brain fog. In our registry, so POTS is postural orthostatic tachycardia syndrome. And it's various reasons people can have it. Viral syndromes is one of them. And these people can faint about 10% of the time, but often they feel very dizzy, lightheaded, brain fog, racing heart rate, fatigue. They struggle in their daily function. And they can feel just really horrible. So, these patients, we found in our registry, the ones that we've have had mild COVID. Most of these patients were their mild COVID were home, never hospitalized. They functioned pretty well with their COVID. They were still working remotely at home, or some even tried to exercise. And often it's sort of they recover from the COVID, and these symptoms kicked in 1 or 2 weeks later, which just shows that the body got sort of maybe revved up in some kind of other response. But many of them were women. The majority of these patients were women. In our registry, it was like 90% or 90%, 90 were women, which often young women, like 20 to 50 some years old, which speaks often women have a very high inflammatory response. We see much more inflammatory diseases in women, which might speak of the virus in their body. Women have a more pro-inflammatory response, which might speak of future research of if things come down the pike of other viral pandemics, other infections, other ways of COVID, maybe we need to do things differently for higher risk groups of higher inflammatory. What we found was interesting, those people were very high functioning people. They had a higher incidence in their daily life of migraines. They're able to function still through their daily life. Irritable bowel, which is often viewed as a neuroexcitable condition, which we believe, and we've been looking at, like maybe susceptible group women, inflammatory things with more of this neural excitable, because POTS has this neural excitable condition. Migraines neural excitable, irritable bowel neural excitable, that maybe the right exposure.
And what is what's neuroexcitable? What does that mean?
That's a great question. Is that your nervous system usually works in a very quiet, calm state, and there's a lot of syndromes or diseases are associated with excitability. Migraine is an excitable state. Seizures are excitable state. Irritable bowel. POTS has a certain neuroexcitability that your nervous system is much more revved up, excited, fastidious, and primed. So we found it was very interesting how high in our registry are long COVID POTS or COVID long haul POTS patients. With general migraine population could be like 10% of the population. Our registry had 60% of our population in our registry had migraine history. Irritable bowel, it could be like 10, 15%. Our registry has 60% irritable bowel. So the idea these people had much more of excitable nervous system with the viral exposure, inflammation, like a perfect storm. And they flip to another condition like POTS, which could be another excitatory nervous system condition, which really poses.
And again, yeah, sorry.
Which,
yeah,
yeah.
Go ahead. Sorry.
You go.
No, I just, again, I want to clarify terminology here because we threw in the terminology POTS. Just want to, we talked a little bit about this before the interview. How can we think of the relationship between long COVID and POTS?
Yeah, so that's an important question, is that long COVID is basically this constellation of syndrome that people are not recovering, and POTS is probably one of the factors or one of the syndromes that's why people are not recovering. We don't know exactly if you have 1 million people with long COVID, we don't know what percentage of the people have POTS. And some people might have POTS and another issue that's leading them to have long COVID. We don't know if people they could have two things going on that leads to it, but there'd be many different factors, many different syndromes or conditions that are leading people to long COVID.
Got it. So the way to think of it is that POTS is a syndrome that long COVID patients can experience.
Yes. Yeah, it is. And it would be great if we could actually look at everybody who has long COVID and really sort of study and analyze everybody and say what percentage develop POTS, and those POTS patients, how many of them have other syndromes that are causing their long COVID.
Got it. And yeah, can you define, really what is POTS then?
So POTS is postural orthostatic tachycardia syndrome. And it really is a certain depth testing that we do to define it, but it really is an inability to have the neurologic control of your blood pressure. People don't realize how much your blood pressure is neurologically controlled. And when you lose this ability, there's different mechanisms through the body that can lead to it. So when people go through it, typical symptoms are you stand up, you get very dizzy and lightheaded, woozy. People's hearts will race. We'll get people's hearts racing up to 120 beats per minute, 150 beats per minute when they stand. And again, they'll feel fatigue is the most dominant symptom, brain fog, that sort of, can't think, impairment of cognition, memory issues. They'll feel very jittery. Sometimes they're misdiagnosed as anxiety disorders because they feel so jittery, sweating, poor sleep. And again, really struggling to get through their day with exercise intolerance, work performance. And it could be, again, these vague symptoms but very important to figure out for people. About 10% faint with it also.
You mean 10% of infected patients from the
POTS patients, 10% of POTS patients in general. Before COVID, there was 500,000 people in the United States with POTS. And now probably with COVID, there are probably, we don't know how many people. There might be more people with long hauler POTS than the pre-pandemic number now.
Got it. And pre-pandemic, like what are some of the causes of common causes of POTS and
mononucleosis, mycoplasm, other viruses, other bacterias, some autoimmune diseases like Sjogren's is associated with it, neuropathy, celiac, head injury, concussion is a big factor. We can see in a lot of people. Chronic health issues can do it. We can see, a lot of the Ehlers-Danlos, this genetic hypermobile condition, is associated with it. We can see at post-pregnancy. And then some people, we don't know always the cause, which always raises concern about, there's probably things about genetic susceptibility that we don't know about. A very, very important question that you asked.
And how about, taking a look back at, past events like with SARS and, other virus in the Middle East respiratory syndrome. Like, do we know anything about POTS from those events?
So some of the research has been interesting because there's been case reports and small series, and we've done some research looking at this idea about people who've had other viruses and why they're not recovering, how they did. And we did some research, and there's some neat studies about what the people had mono, and they went door to door to people, and that 40% of people with mono weren't fully recovered decades ago. I mean, this pandemic has actually given us, as tragic as it is, there's an opportunity for us to really look at people and really do organized research, because we've known from our knowledge, our practice, and daily work that viruses do things to people: direct inflammation, long-term aftermath, long-term consequences. But this is an opportunity for us to really, as physicians, researchers, to organize data for now and long-term for society about this. I mean, there's been things about mono, SARS, other viral syndromes, about people having things and not recovering, and having long-term issues. But this is hopefully going to be an opportunity where we can really, besides helping people, leave a thumbprint for the next generation to say, this is some data you can have as reference points for future other viruses. And I mean, hopefully we don't have other pandemics to this magnitude.
But if we do, hopefully we can learn from our lessons from this pandemic and take it
Well
on for the future, right?
Well said.
And how about in terms of wondering what we know about COVID vaccines and risk of long COVID? I was wondering, is there any data in terms of, for like the vaccinated against the unvaccinated, or are the vaccinated at like lower risk of long COVID if they do get infected compared to the unvaccinated who do get COVID?
So the question I can answer different ways. Can you be more specific? The question, because it's a question of long COVID, should they get vaccinated?
No, I was asking, like, for people who are vaccinated, but they do get COVID, are they at lower risk of getting long COVID?
Yeah,
compared to those who are unvaccinated.
Yeah, I mean, it seems like the people who've been most vulnerable so far, also is that 2020, 2021 strain of COVID, the unvaccinated, that wave of the brutality of the virus. The Omicron wave, we're waiting to see what comes through still. I mean, that winter has been very harsh, what we all went through as a culture and a society. We'll probably be seeing the next few months what might be the long COVID phase of the Omicron. So could it be, it's, and I think you made a very significant comment, is we just went through 2 years of a virus changing itself, as we've also changed society with active science, vaccine, virus changing. But there was definitely something about people doing worse off 2020, 2021, unvaccinated, getting this long COVID, just doing worse than the vaccinated. I've not really seen as much of the vaccinated developing long COVID necessarily. And I've not seen yet so much so far, and it might be early yet, and I don't want to say it's absolute early. I've not seen with the Omicron so much long COVID from that. So who knows, as the virus changes, we'll be seeing different things. We just got to be very attentive.
Got it. And last question here, Rob. For patients, infected patients, like you mentioned, who are, who just feel like life isn't the same for them, after getting infected with COVID, and, really hoping to recover and get their lives back. What are your recommendations in terms of how they can get better? Like go see their primary care doctor for referral? Like what are some of the first steps they can?
Nicholas, I think that question was really essential and paramount. You just can't lose hope. And that's probably one of the most important things. You just can't lose hope. When people don't feel well every day, and it's easy for I to say this as a physician, they can't lose hope. When people don't feel well, it takes a lot in yourself to really pull yourself up and try to feel hope. That's a big ask, A-S-K. I'm asking people to feel hope when you feel so lousy. And a lot of these people have had a lot sort of stripped from them, their jobs, their family. People don't believe them. They stop believing in themselves. They believe in their future. They stop believing in everything. And they got to have hope in the present and in the future. So they really got to consciously choose that things can be different. And it's probably almost initially not even talking medically, but just talking as a human to human. And then really is trying to find someone medically who will listen to them and help them. You know, there's recovery clinics, there's COVID long clinics, whatever your area has for you, please be seen. There has to be resources for you there to help you out. Many people's lives have been just an upheaval, and some level to be understood and figure out what the missing pieces is. Maybe it's not COVID POTS. Maybe it's something else. Maybe it's something else going on. But you know, there's a lot of people's lives that have just been ripped apart in this process. So human to human first. You gotta really just can't give up. You gotta try to choose to have hope, and then find resources if you can in your area at that level.
And resources like you mentioned, like there are hospitals, you know, around the country that have set up clinics to help long COVID patients recover, right?
Yeah. That was my dog. But really is local places have COVID recovery clinics. You can search online. I had one person who went to their local church and they helped her find out. I mean, really happy if you have a best friend, someone you can really help you. If you feel that fatigued and brain fog, it could be a tall thing to do, a tall order. Where do I find? You know, look at your local medical center, your biggest medical school in your area. They might have a resource. And we had patients sometimes who run out of health insurance, and they've actually reached out to the local biggest university, and they got plugged in through resources that way. So it's really is how to start from that level. You know, state resources, your local state, your local county. And these people feel often so ill, they might really need a friend indeed to help them search online or search local resources.
And how about for the Cleveland clinic where you work? Is there, is there a clinic to help, long COVID patients recover?
Yeah. We have a recovery clinic, and they're very resourceful because there's a high demand. I mean, who knows how many millions of people are out there who are just not recovering, but we have millions of people out there, but they'll get people in. I mean, there's a person we think this person needs to come to neurology, not to this person. So they'll route people to the right people. And we try to work collaboratively. It's interesting. A lot of these clinics are not necessarily like a freestanding building that says, come to the recovery clinic. It's more about people working collaboratively, and they'll say, you're going to come to this building here, and then you're going to go to this building here and see these people here. And so really trying to help people out. But truly, I think people often, you see these people in the office virtually, and they feel so defeated and they lost hope. But you can't lose hope to find answers.
Got it. Is there anything else I forgot to ask or you'd like to add about this topic?
No, I think you really covered it. And I think the other thing too is that though we're 2 years into it, and though culturally people are maybe tired of hearing about COVID, I think there's a medical community out there that's still willing to help people with long COVID and discuss COVID. I just want to say that. And Nicholas, I really appreciate you doing this and all your reach out and organizing this.
Yeah. Well, thank you so much for your time, Rob. And for our audience, if you've missed any of this live talk, we'll have a recording uploaded on our YouTube channel. And if you haven't signed up for a newsletter yet, don't forget to do so. on our website. Thank you, Rob, again for joining us, and
My
thank you
pleasure.
for the audience.
Everyone take care of themselves. Take care.
Bye.
Bye-bye.